if you just join, just remember always to mute yourself when you join on a Zoom call. You're not automatically muted. If you unmute, then of course that means you've given permission to be recorded. So good afternoon. Thank you to Wonderful Wednesday. And today we're going to talk about a case study, syncope, non-sustained ventricular tachycardia and cardiac arrest. And what's the relationship here? What's really going on? So first, I'm going to start with the emergency admission of this patient. This was actually on 11/13 or 11/16, just 2 weeks ago. This is an 87-year-old African-American male who has a history of hypertension and who says he's had 3 heart attacks before. He presents today with a syncopal event. He was at his doctor's appointment because he had been feeling quite dizzy and quite uncomfortable. And so he was going to his primary care provider, and he was sitting in the waiting room when all of a sudden he started getting chest pain, had a very warm sensation in his chest, very lightheaded, and he collapsed. He reports that he woke up to clinical staff performing CPR on him. Now, per the staff says, well, he didn't have a radial pulse. Well, okay, for me, that's probably not that important because you might not feel a radial pulse on an adult. Usually you're doing a carotid pulse, but they did 2 rounds of chest compressions. And the patient said, I don't really think my heart stopped. Cardiology also said, I don't really think his heart stopped. Really just sounded like it might have been syncopal. And he's been experiencing these episodes of lightheadedness for about 3 months. And he says that oftentimes they're associated with chest pain. He describes chest pain like what you would expect, a tightness with no aggravating or relieving factors, meaning it's not because he's exercising or walking to to his mailbox or walking to the TV, and it's not relieved by rest. He also says that he has some dyspnea on exertion, and he has it at rest, and he's been having that for several months. So he's been having an ongoing problem for several months. He complains of orthopnea and lower extremity swelling, but says that he doesn't really have any problems at night that wake him up from sleep or require him to sit back on 2 to 3 pillows. That's what PND means, you wake up from your sleep. He does have orthopnea. It's got 2-pillow orthopnea, but he doesn't have PND. So he's not woken from his sleep with this shortness of breath. And in the ED, he's noted to have frequent PVCs on his EKG and on his bedside monitor. And because of that, and because of the history, he receives an amiodarone bolus of 150 milligrams, and he has some improvement in the frequency of his PVCs. His high sensitivity troponin is 19. Now, I want everybody to remember, with high sensitivity troponin, remember that's 1,000 times your standard troponin. For a man, troponin has to be greater than 20 to be considered significant. But if you have concern after you measure the first troponin, you'll do a second troponin within 1 hour, and you'll see if there's a change of at least 5, which then would also indicate that you are having some issues. Second pass is the cardiology fellow who sees the patient. He confirms his identity as ER. I'm not sharing his name. He's an 87-year-old man. He self-reports. Now, he self-reports that he has hypertension. He says he's been at Grady before, but no one can find his former charts. He says he's an Emory-Piedmont patient, but they can't find any records. And the patient says, I have hypertension. I've had 3 heart attacks. And the last time I had one, it was about 15 years ago. And again, kind of complaining of those things we've discussed already: pre-syncopal, warm flushing sensation, chest tightness, things that occur at rest over a 3-month period of time. And again, so the clinical staff at his doctor's office, so remember, they are probably BLS certified, they may not be ACLS certified, and they may not even be BLS certified, but they felt like they couldn't palpate a pulse, so they start chest compressions, and immediately the patient regains consciousness. So they call EMS, EMS brings the patient, he receives that amiodarone bolus. Patient reports that he's been shocked before about 15 years ago, but he's not certain whether that was cardioversion or defibrillation, whether he was awake, whether he was unconscious. He is very iffy on his story. Plus the fact, he's 87 years old, so it's probably hard to remember 15 years ago what your shock was for. You're not a medical provider. He says he is a regular outpatient cardiac patient at Emory or Piedmont. He was seen 6 months ago. Again, couldn't find any records. He also mentions that he's been evaluated before for a pacemaker, but he didn't get one. Unclear whether he didn't get one because he didn't want it or they didn't give it to him. We don't know that. It's a very kind of iffy, soft history, and it makes it very difficult to really figure out what the timeline and the process for this patient is. He has intermittent cold and pain in his bilateral lower extremities. I'd immediately always think of that as possibility of claudication. That's what I would think about. And he also shares that he doesn't smoke, he doesn't drink, he doesn't do drugs. He takes care of his autistic son, who's an adult, who lives with him. And we're going to go over his home meds in just 1 second, okay? So second pass cardiology fellow says, this is the patient who has syncope. It appears that this was syncopal and not really a cardiac arrest, that he may have had a dysrhythmia that reduced blood flow to the brain, he passed out, or he may have had a vasovagal attack. We're not really sure, but he presents to the ED with bradycardia and frequent PVCs. He also says that he has a history of coronary disease, but that's patient reported. We don't have anything that tells us that. And later on, when he gets tested and evaluated, it doesn't appear that he has had any kind of coronary circulation problem or any prior myocardial infarction. Again, remember, this is the patient history. He's 86 years old. He's lost consciousness. So it's all really important to kind of include that in his evaluation. Now, as he presents now, he's not hypertensive. His blood pressure is 150 over 90, but he's 86 years old. So that's not really classified as hypertension. He is quite bradycardic, and he does have a first-degree AV block. Now, they said their PRs, I think what they meant to say was 0.22. And the troponin, his first one was 17. He got another one an hour later. That was 19. So that rules him out for an acute cardiac event. Remember, for men, high sensitivity troponin must be greater than 20. And if you have an index of suspicion and you do a second troponin, you must have had a change of 5. So nope. And his BNP is 155. So yes, it's a little bit elevated. Typically, we say we're going to be concerned about your BNP when it's 200 or greater. Remember, that's your beta natriuretic peptide hormone. That indicates that you have heart failure. His electrolytes are acceptable. Nothing really appears that abnormal, except that he has a very low glomerular filtration rate, somewhere around 40, 35 or 40. But his BUN is not abnormal, and his creatinine is mildly elevated. We don't know what his baseline is. Again, remember, he's 86 years old. His creatinine is 1.9. So without knowing a baseline, we couldn't find anything from prior visits to really evaluate that baseline creatinine. It's hard to say, except that his GFR is really, really, really inadequate. So that makes you think that he's got some kind of kidney dysfunction that's occurring at this time. And on EKG, of course, he has sinus bradycardia. He has a first-degree AV block. He looks like he has a left bundle branch block. He looks like he may have some left atrial hypertrophy, and he's having PVCs, but there does not appear to be evidence of any acute infarct. And he does ultimately get a CT for PE because they didn't know what to do with this guy. They threw everything at him. And he got a CT for PE, but that was negative. His home medications, which he had all the containers, so he shows them. He's on losartan at 25 a day, hydrochlorothiazide 25 a day, cardizem 120 a day, DIG at 0.125 a day. Now, I want you to remember these meds. I don't have a list of them going forward, but I want you to remember them as we move forward in what we discuss of what's occurring for this patient. So this is his very first EKG. And this EKG, I'm sorry, I have this included up here, but you don't know who it is because he's got a stat pack name. You take a look at this EKG, and it's really profoundly and significantly important when we're looking at this EKG, that you see that current is going towards the left. So lead 1 represents the left side, AVL represents the left side, V5 and V6 represent the left side. So when that is above the baseline, that means current is going to the left. Well, that's normal. It should always go to the left, but it's taking a lot of time. So we're going to call this a left bundle branch block. And you can see that he's relatively bradycardic and that his PR segment or his PR interval is about 0.22 to 0.24. So he has a first degree AV block. He has a left bundle branch block. It looks like he has atrial enlargement. That's LAE, atrial enlargement. We determine that typically when we see a biphasic P wave above and below the baseline. You see that in V1, you see that in V2. Sometimes you'll also see it in lead 2, although we don't see it there, but we do see it in V1 and V2. That gives us an indication that he has a left atrial enlargement, probably related to left ventricular hypertrophy, but we don't know that yet. And right at the very end, we see that he has a PVC. Okay, so then we move forward and we see the next EKG. Okay, so let's go look at the first one. Okay, Rogelio, I know you're on the call, so take a really good look at this. Take a look at lead 1, lead 2, lead 3, AVL, and then look at his next EKG. Okay, well, now all of a sudden, instead of being upright in 1 and upright in AVL, he's downward, and that's because the leads were on the patient incorrectly. So very important because, by the way, if you ask your tech to print that out, it tells you right away the right and left arm electrodes are reversed. Please fix them. We need our EKG to evaluate our patient, but I guess nobody noticed it, or they didn't look at it, and maybe they looked at the EKG later and they said, oh, look, something's really changed. No, his electrodes are in the wrong place, okay? Still got the same problem that we talked about before. It's just a little bit harder for us to see because our electrodes are placed appropriately. Okay. Second pass by the cardiology fellow. Remember, he's come to see the patient. He kind of reiterated what the ED resident said is he's really concerned about this patient. He doesn't really know what's wrong, doesn't really think it's an acute coronary event, says, let's get an echo. Let's obtain a thyroid stimulating hormone. Let's look at his lipids, look at his A1C. And by the way, stop giving amiodarone right now because we don't really know what's wrong with the patient. And of course, we'd like to control his ventricular arrhythmias, but along with that syncope, I need to have a bigger and broader perspective. And remember, the medication bottles came and he's on DIG and losartan and cardizem, et cetera, hydrochlorothiazide. And try to get the potassium greater than 4 and the magnesium greater than 2. His mag was a little bit low, but the potassium looked okay. And he says, listen, we need to really take a look at this patient under nuclear imaging. That's going to be the most important thing we do. So we're going to get an echo. We're going to get an exercise stress test with nuclear imaging, probably going to do an MRI. Maybe we'll think about a cardiac cath. So make this patient NPO at midnight, and we're going to admit him to the hospitalist service to step down or telemetry. And that's where the patient's going to go from the ED. Okay, so then again, we see very quickly, we see our next EKG. And I'm so sorry because I did put a blank on that before, but it just disappeared, so no problem. Okay, so we see that next EKG, and here are the normal beats of the patient. So in lead 1 and AVL, they're upright and wide. Okay, in V6 and in V5, they're upright and wide with T waves that are inverted. That tells us that's a left bundle branch block. But now we're seeing some more frequency of ventricular premature complexes. Now, here's a time when your computer is making a mistake, okay? These are, you can only know if somebody is having multiform PVCs by the rhythm strip. Okay, so by this rhythm strip, I'm not certain about this. I don't know what really happened here. I don't think it's another focus. By a rhythm strip, you have to see really shifts in direction and big changes in the way your EKGs actually look in order for you to say it's multiform. So for right now, I'm going to say, really, it seems pretty uniform to me. I'd like to see something more aggressively different than this one. This looks like it might be even a fusion beat. I'm not positive. Patient still has first degree block. He still has left bundle branch block. He still has left atrial enlargement, so nothing's really changed. We're getting a little bit more frequency of the PVC, but we don't really know how much more frequent that is because we didn't really see it from before. Okay, so I'm going to go back here and I'm just going to call your attention down here. And you can see, of course, when you look down there, you are indeed seeing, when you take a look at that the patient does indeed have some runs of VTach. So he is, at this point, he is on the med-surg floor and he has some non-sustained ventricular tachycardia. It's unifocal. It has what we call positive concordance, meaning it's all pointing in the same direction in those chest leads, all pointing in the same direction, all pointing downwards. That really helps us to know that this is VTach. And we've had a little bit of warning because the patient is having these premature beats prior to now. He's had a couplet of PVC, and then he goes into VTach. And that VTach is non-sustainable. The patient doesn't lose consciousness. His vital signs don't change significantly. He does actually, at this time, has a pulse, but it's very concerning. It's on a medical surgical floor. That's quite concerning. Cardiology gets consulted, and they're consulted because of this recurrent VTach and ICD placement. He received a nuclear stress test on 11/15, and on that stress test, really important to understand here, they said low functional capacity. Don't confuse low functional capacity with a low EF. Now, they stopped the stress test because the patient got tired. And on 11/16, the patient has significant chest pressure associated with feelings of about to pass out while laying in the bed. He has sustained VTach with rates of 198 to 211. So the decision is made. He needs to get transferred to the CVICU. So all the notes are coming in at different times, and it's a little bit hard to say exactly what happened. But on 11/16, he gets transferred to the cardiovascular intensive care unit. And the doc writes, where the cardiac cath was performed. No, we don't perform cardiac caths in the CVICU, but he did go to the cath lab to have a cath. Okay. Another cardiologist says there's three different ones, two residents or maybe one resident, a fellow, and an attending, and they all three have different statements here. Another cardiologist says, we were called to see the patient because of his VTs, having recurrent episodes, successfully aborted by coughing. Okay, all you have to do is ask him to cough and it stops it. Amiodarone, IV nitro, heparin were initiated, patients transferred to CVICU, interventional cardiology consult for urgent cardiac cath, which was done, and there was no significant coronary artery disease. So the next step is to consider an electrophysiology consult. The exercise stress test by the third cardiologist, he says, stress test is unremarkable. Nuclear stress test reveals that there's a small perfusion deficit in the apical wall and that the left ventricular ejection fraction, that's what he means here. He put H, but he means LVEF, left ventricular ejection fraction. I just copied it directly from the chart at rest of 57%. Okay, well, that's what we call preserved ejection fraction. So patient hasn't really lost his ejection fraction. He still has a functional contractility. His stroke volume may be low, but whatever volume gets into the ventricle, he's ejecting about 57% of it. And after induced stress, he reduces that to about 47%. Now, normally you expect that with stress, you're going to increase your ejection fraction, not reduce the ejection fraction. So this is, of course, quite concerning to us. All right, so he gets admitted to the CVICU. It was hard for me to tell for sure, but I think it was at 10:57 p.m. 86-year-old man, history of hypertension, same thing that we've heard before, and he's admitted to CVICU. The statement says for symptomatic non-sustained VTach. A very, very, very nice note written by the nurse practitioner. Nurse practitioner says cardiology did a syncope workup and noted a depressed EF, but not really. His EF 47%, 56%, that's pretty normal for somebody who's 86 years old. Okay, so we know he got admitted to CVICU for frequent episodes of VTach. He continues to have episodes of non-sustained VTach, that's NSVT, non-sustained VTach on the amio drip. It got continued. Then I think it got started again. And then once he was in the CVICU, they transitioned him from amio to lidocaine into a lidocaine drip, planned to stop the lidocaine at midnight on 11/19 prior to placement of the ICD, which, by the way, he did not get on 11/19, at least from the chart. He got it on 11/20. The request was to closely monitor this patient because of his continuous episodes of ETAC. He has bradycardia, he's tolerating room air, he doesn't need oxygen supplementation, he's not intubated, he's eating, and he has a good urine output. And on these first kind of rounds, I could show you all of his labs, and I will, but basically just the creatinine and his calcium and his magnesium are really the only abnormals. Very little abnormality on his labs. We would have expected to see more. He seemed to be okay in the presentation of continuously having non-sustained VTAC, being lightheaded, having lost consciousness, having received CPR. Within all of that, he seemed kind of okay. He's an 86-year-old guy. He seems kind of okay. So now we look at all his labs. So you see first 11/13/23, first in the emergency department. And then again, this was in triage, and then into the ED, then to 5K overflow, which is a step down floor, then to the CVICU, and then ultimately to the cardiac medical surgical floor. This is his stay. And this is all of his labs during his stay. He wasn't with us that long. He didn't get that many labs. And part of the reason he didn't get that many labs was because his labs were not that, I'm so sorry, were not that unusual. Okay, so we're looking at this. This is really all looking pretty good. This is his total serum CO2, but you see his sodium, his potassium, his chloride. Everything looks pretty relatively normal, except for his glomerular filtration rate. Okay, so remember we said his creatinine is elevated, but we're not sure what his baseline is. And then his GFR is profoundly elevated. And he has a little bit of abnormality in magnesium and a little bit of abnormality in calcium. But apart from that, BNP is relatively normal, troponin is normal. Everything else looks pretty good. There wasn't anything that anybody did wrong. There was nothing that anybody did wrong. But there is something here that is for us to learn about. And I think that's what's really important when we come together. Now, he did get a blood gas when he got to the CVICU. And you can see by his blood gas, things looked okay, not fantastic, right? His PO2 is 86, pH 7.43, CO2 is 39. His base is 1, positive 1. His bicarb is 25. He's looking okay. All his electrolytes look pretty good. The only thing that was a little bit abnormal was the elevation in his calcium. Now that should...
You did get him at the hospital.
Excuse me, if you're on this call, please mute yourself because it can be a problem if you're talking. Actually, I'll just do it for you. Okay, very good. You're going to have to do it yourself. Beatrice, you're going to have to mute yourself because I can't mute you. All right, my friends. So looking pretty good right now. All the labs look pretty good. So we're going to kind of move forward. We're going to look at his echo. First of all, when he gets his echo, first thing they say, which they often do, is the study is limited. It was really hard to do, but it appears that the patient has a very large LV wall with a very small LV cavity. Okay. Big wall, small cavity. All right, so right away, we're going to say this looks like hypertrophy and it looks like cardiomyopathy. And that's exactly what's said by echo. Big, thick wall, small cavity. Okay, this seems to be a type of hypertrophic cardiomyopathy. And the cardiologist says, I think that this is an unusual variant of hypertrophic cardiomyopathy. First thing to think about when that occurs is a protein distribution disorder known as amyloidosis. That's the first thing we should think about when we see this. He also has mild aortic stenosis and a little bit of regurg. Whenever you have somebody who has amyloidosis, it's very common for the aortic valve to be involved. Now, let me just tell you something. It's not common for us to look at somebody with amyloidosis, but when we have a patient who has syncopal episodes, VTAC, who has a large LV wall, we should always start with that perspective that he may have amyloidosis. So that's not really your job, right? That's the diagnostician's job. It took quite a while before the word cardiac amyloidosis appeared in the patient's chart. A lot of tests were done, and I think everybody was thinking it, but nobody was really saying it. Nobody was really sure. But here's the thing. The LV ejection fraction is normal, but he has severe concentric. So that means all around the LV, the wall is thick. The wall is thick. And what that means is I've got to look at that thick wall in some other way, not just with an echocardiogram, which of course the decision was made to do, which was fantastic, right? And he has some apical akinesis. His right ventricle looks grossly normal, which actually in terms of amyloidosis means that you caught it somewhat early, which means that you can treat it more effectively because it's been caught somewhat early. Okay, so he's got mild AR, he's got mild AS, and really everything else looks pretty normal. Everything else looks pretty normal, okay? But ding, 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 he has a small interventricular cavity. So instead of getting 200 cc's of volume in that cavity, he gets a small amount of volume because his ventricle's not compliant, so it doesn't fill very well. It ejects well, but it doesn't have much volume in it. So his stroke volume is low, and that's one of the reasons, assumably, that he is lightheaded. Then he goes to the cardiac cath lab, and with an urgent presentation, but coronary arteries are essentially normal. There might be a little bit of calcification, but the arteries are normal. There's no stents, and there doesn't appear to be any specific area of myocardial dysfunction that would tell us that you had a heart attack. He doesn't have coronary disease. Basically, relatively regular, has a little bit of calcification. They say, oh, well, maybe it's a PE, and he gets a CTPE. Oh my gosh, no pulmonary embolism. Pulmonary artery looks good. I hope my heart looks this good at 86, or at least somewhat this good, because it isn't really good, and he doesn't really have good news. He goes to the MRI, and at the MRI, they're saying, okay, vital signs, symptoms, EKG changes reported by cardiology. And what we see in the MRI is this small fixed perfusion deficit in the apical wall, a nice normal EF, and post-stress, that lower EF, and just refer back to cardiology. But what they see here is this mild aortic calcification. And because of that wall thickening and some abnormal motion, the perspective starts to now focus on cardiac amyloidosis. Okay, so the very first patient, the first person who actually says amyloid is the electrophysiology doctor in his note on 11/17. He looked at the CMR, he says it's consistent. No one said it until 11/17. Remember, patient came at 11/13. On 11/17, the EP doctor says this CMR is consistent with cardiac amyloidosis. So he's discussed that with the EP. I'm sorry, not the EP doctor. Yeah, the EP doctor. So he's discussed it with the EP. Originally, they were gonna do an EP study and do an ablation. They said, oh, no, he's got amyloidosis. He needs an ICD. So first, the thought, the reason the EP doc was called on was because he was going to do an EP study. So when he looks at all the testing, he says, oh my gosh, this patient does not need ablation. This patient needs an ICD. And he probably needs biventricular pacing. But first he talks about ICD, and then he talks about what needs to be evaluated with actual imaging, maybe with a biopsy, and that is looking for these abnormal proteins that occur in amyloidosis that actually absorb different dyes, and that's called light chains. So I'm not telling you I'm an expert on amyloidosis. I have seen 5 patients who had diagnosed amyloidosis. I've probably seen 200 patients who haven't had diagnosed amyloidosis, because it requires that you have somebody who is really looking forward. Now, let's remember, he had a cardiac cath, he had an echocardiogram, he had an MRI, and he had a stress test. But until this electrophysiologist was evaluating him, nobody said cardiac amyloidosis. Now, once he says amyloidosis, everyone else starts to write the notes with the term amyloidosis. But had he not looked at that chart, had he not been consulted, and that particular EP doctor as well, perhaps, maybe we would have discharged this patient without a proper diagnosis. And the problem is that without a proper diagnosis, amyloidosis can exacerbate, and depending on the kind of protein it is, there's different proteins, different protein abnormalities, patients can get discharged from the hospital and be dead in 4 months. So we can actually prolong their life and improve their quality of life with appropriate therapy. So let's just talk a little bit more about amyloidosis. So again, I've worked with 5 patients who had diagnosed amyloidosis that I'm aware of, but I've probably seen many more. Amyloidosis is basically a disorder of circulating proteins that fold basically in the wrong way. They don't get dissolved, and they get deployed and deposited into tissue. Okay, and there's multiple types of proteins. Probably not that important for us, although you want to be aware. There really are 2 main types of proteins that we talk about with the kinds of patients we see, and that would be AL or the TTR. Now, the perspective is that this patient has TTR amyloidosis. TTR is basically the protein that transports thyroid hormone. And that TTR, that thyroid hormone binder, actually folds across itself and gets deposited in the cardiac tissue. And so you have this aggregation and deposition of misfolded proteins. So remember, protein should be soluble, it should dissolve, but this is folded the wrong way, so it doesn't dissolve, and it gets deposited into the organ. So now we're talking about a very highly sensitive organ that has to have cell-to-cell communication for electrical conduction and mechanical contraction. And now you have these non-conducting proteins that have been deposited into the muscle. So now that affects depolarization, of course, and it also affects the compliance of the heart, which is exactly what we've seen. That's exactly what we've seen. There's even a journal called Amyloidosis. It's a journal. And what's really amazing is that by American College of Cardiology's evaluation, that less than 25% of cardiologists actually diagnose amyloidosis in their patients. Now, red flags. Number 1 is age. Number 1 is age. On echocardiography, the thickening of the septum, the thickening of the posterior wall, the thickening of the LV, and if it is more advanced, you'll also have thickening of the RV free wall. You have alteration of your valves, and patients typically can't tolerate beta blockers or ACE inhibitors. And typically, if they had a history of hypertension on their presentation, they may have a normal blood pressure. Okay, so that might be true for our patient because he said he had hypertension, but his blood pressure is relatively normal throughout his stay. So he may have had relative hypotension in conjunction with this amyloidosis. Now, for the AL form of amyloidosis, you typically are going to see patients have preserved ejection fraction with nephrotic syndrome, something similar to what we've seen. They also have orthostatic hypotension. They get these deposits, actually kind of deposits of the protein. So you can see kind of protein deposits in their tongue. Oftentimes they'll have bluish or raccoon-like eyes, paraorbital purpura. I don't know that about this patient because I didn't see him, but there are people on the call who did see him. And a lot of times they have peripheral neuropathy. But what the perspective about this patient was that he has the ATTR, that's the thyroid carrying protein, ATTR amyloidosis. Now look at this, 92% of folks less than 75 years, 92% have heart failure that's no amyloid, but 8% less than 75 years have amyloid, and that completely transitions when you get past 75 years of age. African Americans greater than age of 60 present with a preserved ejection fraction, and they may or may not have a history of hypertension, but they have a new diagnosis of hypertrophic cardiomyopathy. Okay, well, our patient gets a diagnosis of hypertrophic cardiomyopathy. We don't have his old records, so we don't know if anybody said it before, but also they have kind of a low gradient aortic stenosis. It's in an elderly patient, and sometimes they have a family history. That would have been a very hard thing to get from this patient. Also, 86 years of age. Even if his parents had it, they probably would never have seen a doctor or never been diagnosed. Okay, but I love this picture. So what you are looking at is a slice here, and you're seeing all this highlighted pink tissue, that really light pink. That is all infiltrate into the LV and the septum. So here's your RV. This is an advanced case. Here's your LV. Here's your RV. Look how narrow the chamber is. You barely can get any volume in there, barely any volume in the RV. And you're seeing all this speckling, that's what we call it, or this light pink infiltrative material. And that is the amyloid. That's the protein that's been deposited. It causes profound distortion of the myocardium. It makes your tissue very stiff, and now you're in complete organ dysfunction. But even more importantly, with ATTR amyloidosis, you have a disruption of mechanical and electrical events, or electrical chemical. So that's just basically saying prolonged PR, prolonged QT, abnormal rhythm. And so most apparent in the ventricles that the patient now has what we call restrictive myocarditis or cardiomyopathy. Restrictive cardiomyopathy, meaning that the heart can contract, may not be great, but it can contract, but it can't distend, so you can't fill. That's called diastolic dysfunction, a failure to fill. So now you start to see valvular dysfunction, malfunctions, you see AS, you see AR, and you actually start to see some vascular infiltration. Okay, so I don't think it's really important for you to know all the different chains, AL, AA, TR. Don't worry about that. What I want you to understand is that if he indeed has the TTR amyloidosis, you can't know that until you do further testing, the site of the production of those abnormal proteins are the liver, and they are highly deposited in the heart, okay? If you have AL, the site of production is the bone marrow, and the organs that are involved are also going to be the heart, but not at such a high level. So here's the thing. You're going to treat this, you're going to evaluate this like it's cancer. So that means the cardiologist now has to give it up to the hem-onc team, because we're going to treat this because this is an abnormal cell and an abnormal cell function that's produced in one place and deposited somewhere else. We've got to really treat this aggressively with hematology oncology involved with the evaluation of the patient. Now, this is not our patient, but if you just take a look at this normal patient, you're looking at the septum. You can see here in a patient with amyloid deposits in the heart that you can certainly see that the wall of the ventricle is quite enlarged on both left and right side, but also look how large that septum is. So that's a really important factor that we can look at when we talk about the echocardiogram. This is from the American College of Cardiology. It's just a diagnostic approach. I don't want anybody to be worried about it. I'm just saying, when you see a patient with increased LV wall thickness, we think about three things. First of all, their wall is thick, so we say hypertrophy. Is that because they have uncontrolled hypertension? Is it because they have hypertrophic cardiomyopathy? Or do they have infiltrative restrictive cardiomyopathy, which Most of the time is going to be related to amyloidosis, okay? And that's what we're seeing here with our patient. That's what we think we're seeing. We don't know that until he gets further evaluation, gets different protein testing. He might have to get, I don't think he will, but he might have to get a myocardial biopsy so we can really take a look at the cell and see what's occurring there. Okay, so EP on 1120. Says preoperative diagnosis, 86-year-old hypertension, MI, VTAC, cardiac sarcoid, and class 2 heart failure. By the way, class 2 heart failure. This man, I mean, he's 86, so, but if he had good therapy, he could live for another 10 years if he has good therapy. Okay. What does EP do? They do something perfect, right? They give the patient an ICD. Now, there's a lot of controversy about whether ICD really works for amyloidosis. Some folks believe that cardiac resynchronization, biventricular pacing might be the best approach, but what our patient got is an ICD, and there's a lot of controversy about it. So this is what our EP wrote, okay? And on 1124, this is his discharge note. And I found this to be so helpful because it really laid things out. On 1115, the patient got a nuclear stress test. He has a mild perfusion deficit in the apical wall. Okay, and normal is the deficit, the perfusion deficit less than 1.2, and his is 1.08. So he looks good. He has a pretty normal LV ejection fraction, but he has bradycardia, prolonged PR interval. He has LVH, and he has repolarization abnormalities with T wave inversion LBB. Okay, we knew all that, right? Didn't really have any EKG changes. Didn't really have any significant dysrhythmias and physiologic stress. So you know what? By the way, his heart kind of looks okay right now. On 1116, he gets his left heart cath. Everything's normal. And then he gets that CMR. And on the CMR, they see that whole thick appearance of the LV, particularly along the mid-cavity. And mid-cavity means close to the septal wall. This is consistent with cardiac amyloidosis. Now, remember, he came in 1113. We're now at 1117, which, by the way, is fantastic. Very, very fantastic. Okay. They think that this is amyloidosis because of the way the muscle looks. Okay. So that is really profoundly important. He has amyloidosis. And on his discharge, they also say he had syncopal events, status post VTAC, status post ICD. He got amiodarone, lidocaine, and ICD, put on PO amiodarone, and he's going to get his device checked on 12/5 in the cardiac clinic. And then the concern for cardiac amyloidosis, which means you got to do something pretty quick. And they're going to take a look at a couple of different proteins and different protein smears. So first, they did first evaluation of proteins that they could do in the blood, and the findings were neither positive nor negative. Definitely need hem-onc. And hem-onc says, we're going to do a scan looking for these proteins in the myocardium. And if that's positive, then we're going to do a cardiac biopsy versus a bone marrow biopsy, maybe even a liver biopsy. But hem-onc now is taken over. Cardiology is done. Really, we need hem-onc now. Hem-onc needs to follow the patient for cardiac amyloidosis, okay? Hem-onc's note on 1124. Unfortunately, I'm unable to perform the test because of limited staffing during Thanksgiving holiday. The soonest we'd be able to do this would be Monday, 11/27, as an inpatient, but the patient doesn't want to stay in the hospital. He feels pretty good. So we're going to let him go. The primary team says it's okay. We're going to let him go. And we want to repeat and we want to evaluate this PYP, this protein scan. We want to repeat that as an outpatient. But before we're going to consider a cardiac biopsy. Now, of course, cardiology will do the cardiac biopsy, but it's still under hem-onc's control. And I want to just say here, says outpatient malignant heme clinic referral has been placed, and we will arrange for follow-up. So as of today, so today is 11/29, I think. 11/29. As of today, there's no hem-onc appointment. There's no hem-onc referral that I see in the chart. I see the cardiac clinic appointment for 12/5, but no hem-onc follow-up. From my point of view, that's something we need to make sure this patient gets. He was kind of He was a little bit ornery. He didn't want fluids. He didn't want his IV. He didn't want this. He didn't want that. He's 86. He's like, let me alone. But he has to also appreciate he doesn't have to do anything you say. But we want to be sure that he understands that this is a treatable disorder and that we can improve his quality of life. Maybe he doesn't want to live another 10 years, but we can improve his quality of life by good management. But we've got to have a firm diagnosis first. Okay. So for general amyloid treatment, how patients should leave you in the ICU. First of all, you should be suspecting this in patients who have these kinds of non-specific presentations like this guy. Nobody could really find anything until he had his CMR. And then you see that he has this hypertrophy, but because of the pattern, it doesn't look like standard hypertrophic cardiomyopathy. It really looks like amyloidosis. For general amyloidosis, okay, initially you're going to avoid ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, and digoxin. So I just want to remind you, your patient is on an ACE, a CCB, and digoxin. Okay, now that's may or may not, the ACE and the CCB are not going to hurt him. Digoxin, though, gets deposited in those proteins and then promotes dig toxicity. So he should not be getting digoxin. And he didn't get discharged with digoxin, so that's good. Definitely want to give diuretics. You're going to give both loop diuretics and aldosterone antagonists. So typically something like Bumex and aldactone is how patients get discharged. They get an AICD. Most of the time, patients with amyloidosis have sudden cardiac death because of electrical mechanical disturbances. So the AICD is going to take care of that. Lots of discussion in the literature, no pure 100% consensus in the guidelines that says biventricular pacing may be very helpful. Biventricular pacing is only helpful if you have to actually pace your patient. Now, remember, he has bradycardia, and that bradycardia actually limits his ability to increase his cardiac output. Now, he has a good EF, but his stroke volume is low because you can't fill his heart because his heart is a stiff little chamber. So he has a very low stroke volume, and if he needed an increased cardiac output, he would have to be able to increase his heart rate. That would be the reason to consider a pacemaker for this patient. The problem is that if you just do a standard pacemaker that is univentricular, and that doesn't help these patients. They have to have biventricular pacing. So if the decision was made to give him a pacemaker, it would need to be biventricular. Right now, he just has an AICD. They also have to be placed on anticoagulation, even if they're in sinus rhythm, because once they have that amyloid infiltration, and that's in the ventricle and it's also in the atria, they're going to have some impairment of contractility, particularly of the atria, and that will lead to blood stasis and thrombosis. Other things that they have, a lot of times they have problems with diarrhea, they have problems with constipation, they have problems with GERD and gastric reflux. So put them on some good non-cardiac medication for their management. You also would like to help control their orthostatic hypotension. Now, if you have a biventricular pacer, you're going to have a higher heart rate, you're going to have a better cardiac output, you're going to have less orthostatic hypotension. But if the patient loses consciousness, as our patient did, he's having syncopal episodes, right? They might need something like midodrine or other kinds of agents to help avoid orthostasis, right? And you dose them early in the morning, you give them a noon dose and an early afternoon dose, but you don't give them a nighttime dose. Encourage them to wear compression stockings or abdominal binders. He doesn't drink. You also have to avoid really hot showers, and you need to eat a regular cardiac diet. But there are lots of ongoing challenges here, because 20 years ago, if you had amyloidosis, you were going to die. If you have AL amyloidosis, you're going to die within 6 months of diagnosis. With ATTR amyloidosis, depending on what kind it is, familial or congenital or acquired, you may actually survive more than 5 years with good therapeutic intervention. But historically, treatment was not available. Now, depending on, is it from your bone marrow? Can we do a bone marrow transplant? Is it from your liver? Can we do a liver transplant? Or we're not going to do either one of those on this patient because he's 86 years old, but he can go on some disease modifying therapy. And those actually stabilize the proteins and protect you from having more protein deposition. So very important to think about these different therapies. These are all hem-onc therapies. These are not standard therapies that anybody in the ICU or anybody in cardiology is going to talk about in their standard conversation, right? So TTR, think about liver transplant, and also silencers. So these are the agents, that's the chemical name of these agents that actually silence the TTR, that's that thyroid protein that carries thyroid hormone. It silences those TTRs, those folded TTRs. You can also stabilize them with some other types of chemotherapeutic agents. Again, that's under the control of hem-onc. And then you can disrupt or actually promote reabsorption or resorption of the amyloid fibers. And that amyloid fiber, remember, that amyloid fiber is what is the end product of that misfolded protein. You have that amyloid fiber. We can put patients on monoclonal antibodies. We can use doxycycline. So there are opportunities for therapy for these patients. There are opportunities, but they will not happen without a definitive diagnosis and without hematology oncology oversight, because we're treating this as an abnormal malignant cell with deposition into your organ. You need aggressive treatment. So I have concern when looking at his chart. I'm actually going to communicate to the cardiac clinic. I'm going to ask the head of the cardiac clinic to assure that when they see this patient on 12/5, that he gets a hem-onc consult, because hem-onc said they were going to do it, but oh my God, it's Thanksgiving. They were probably exhausted. They were doing all of the other patients that maybe they wouldn't normally see, and nothing was put forward for a hem-onc appointment. So I want to be sure he's going to get seen by hem-oncology. He might not want it. He might say, I don't care. I don't care about it. I don't mind if I die. It's really okay. I'm 86. I've had a good life. I mean, he has a choice, but we can help him, but not in the traditional ways that we help our cardiac patients. So this is also from from Circulation, which is one of the journals for the American College of Cardiology, is in the affirmation that you have that amyloidosis. Really, we have to look at utilizing these off-label and chemotherapeutic agents. Those are really what need to be done. And that's why you must get this patient to a hematologist to actually perform specific biologic testing, specific evaluation, genetic testing, so they can make decisions about what we can do for our patient. And you can see over here, right, that you've given you didn't give the patient a pacemaker. He might have benefited from a pacemaker plus an ICD, but anyway, he got an ICD, right? Because we want to abort sudden cardiac death in the patient. You might get cardiac resynchronization therapy with his pacemaker if he needs that, right? Remember, you might start with a standard pacemaker, but over time, that's going to limit their LV filling and ejection. That's why they often need biventricular pacing. And again, you might put them on vitamin K, DOAC vitamin K inhibitors or antagonists to suppress clot formation because of their dysrhythmia and because of atrial dysfunction. But look at this. Everything else, my friends, everything else is hematology and oncology. So by the way, congratulations to the CVICU, to the 5A, to the 5K overflow, and to the emergency room. They did a fantastic job managing this patient, and in 4 days had narrowed the diagnosis. Now, one of the reasons that got narrowed is every single cardiac test that we have, we gave this patient because he kept sailing through the test without anything wrong. Thank God he had somebody who was really monitoring that, making sure that the testing was done appropriately to help evaluate the patient. So I just want to review one more time cardiac complications of myocardial amyloid fibril deposition. Severe heart failure, initially preserved left ventricular ejection fraction, but decreased LV compliance. So we know that he has preserved left heart ejection fraction, right? 57 down to 46 with stress, pretty good, but poor LV compliance. But right now, he does not have severe congestive failure. So over here, I said not yet. Decreased LVEF may follow diastolic dysfunction, terminal and fatal heart failure. Not yet. Chronic elevated LV filling pressures, atrial thrombi, not yet. Non-sustained or sustained ventricular dysrhythmia, yes. Conduction disturbances, yes. Orthostatic hypotensive episodes, yes. Amyloid deposits, microcoronary circulation deposits, chest pain, but big vessels are completely free of significant stenosis, yes. He meets more than half of the criteria. And what that means, and maybe not for him because of his age and because he is not really interested in participating in his wellness, but in every patient who you see as confounding, who has an echo that talks about LV hypertrophy, we should always consider the possibility of amyloidosis. The belief is that it is underdiagnosed in a significant portion of patients who present with heart failure, that it is underdiagnosed. So it's just something to consider. And for us to think about conduction disturbance plus orthostatic hypotension plus chest pain with clean coronary arteries, think about cardiac amyloidosis. Thank you very, very much for being with me today. I appreciate it so much. That's the end of the conclusion of our wonderful Wednesday and our recording. But those of you on the call, I will be back for us to have some further discussion. Bye-bye for now. Stop recording.